Good evening, everybody. My name is Chris Jordan from Tygerberg Department of Orthopedics. Thank you very much for joining us tonight in this first of a four-part virtual meeting series for the South African anterior approach interest groups. From the start, I'd like to thank Michelle and Advanced Orthopedics for their commitment to education with us. They partnered with us and they provided the technical and logistic support for this meeting. So I work in Tygerberg Hospital, and this is a picture that we took from the hospital during this COVID period. And sometimes it can actually be quite pretty, and I really enjoy my work and the place that I do work. But as all of you are aware, COVID came around and changed the way that we work, changed the work that we live, and to a large extent it changed everything. So initially I was quite excited by this, and we attended quite a lot of webinars. There's the current concepts, as well as then a legio of company-driven webinars. And it was great, but I become irritated because it wasn't focused for the South African market. It wasn't focused for the South African surgeon. And it almost felt like we had very little voice on all of these platforms. So in the end, it actually became that we stopped watching a lot of these things because of it's not applicable to our current situation. So now, on the other side, we've got anterior hip replacement and post-hip replacement and anterolateral hip replacement. And the anterior hip surgery is controversial. Doesn't matter where you are around the world. There are those that love it and actually believe that it makes a big difference for their patients. Then there are those that are vividly against it. Ironically, most people against it cannot perform the anterior hip surgery, and therefore their opinion remain biased. But the aim of this meeting was not to really say anterior is better than anything else. The aim for this meeting was to bring a group of surgeons together that operate on hips and to talk about our common problems and our common struggles, especially around the anterior approach, but also to talk about our common victories and the things that makes us continue with this and to experience this. In the end, I am in the academic setting to train people and to help people, but it's about our patients, and we want to perform safe surgery on our patients, and we want to have all happy patients. So this is the start. So initially we talked about these meetings and we wanted to have it in person, and then it was only a selected 10 to 14 people that we want to invite and to discuss and mill around this, but the virtual platform opened this up. So we've designed this 4-day program. Day 1 is today, where we're going to talk about the concept and change. The second time, we're going to talk about the academic side. We're going to go robust, the academic side of those for the anterior approach, the academic side against what the research and literature shows us against the anterior approach. So, and we're really going to look at this from an academic point of view. The third one, we're going to actually try to look at it from another side. So we're bringing in Prof. Chetty from anesthetics that's going to talk about what is new in anesthetics and hip surgery. Dr. Tron, also from anesthetics, that's going to talk to us about pain relief and perioperative pain management, especially in the time of ERAS, as well as rapid mobilization. And also Liana Lowe, which is a physiotherapist that, and you will be often surprised that the physiotherapist got a completely different side of the patient. And in our hospital, she's quite the integral part of the team. And then after that, all of these sessions, the fourth one is going to be the nitty-gritty, the fine script on how you do it, what you do, and just the things that distinguish your difficulties. So we got together a panel of surgeons around South Africa, really a great bunch of guys from right across South Africa that are all involved and doing anterior hip surgery. So when you hear someone speak, it's someone from South Africa that is working in our environment, and they really understand what this is all about. So coming back to Tygerberg Hospital, I want to tell you just quickly, briefly, my road to happiness. My road to happiness started in Stellenbosch, where I studied medicine, went to KZN, where I did orthopedics. And in my fellowship period, we trained, so in my registrar's time, we trained anterolateral surgery. In my fellowship period, we trained posterior surgery. And when I joined Tygerberg in 2014, I was a happy, exclusive posterior hip surgeon. I was happy, I was content, my patients was happy. And every time I ventured and looked at someone doing any other approach, I always thought, sure, it's such a struggle, so why bother? My road changed in February 2017 when I was invited to go on a 5-day tour of anterior surgery in Belgium. Now, I must confess, I really thought this was a beer tour, and with Belgium having the biggest variety of beers, we really tried to utilize this opportunity as a beer tour. But I was quickly reminded the first day when I met this gentleman, Dr. Ronald Driessen in Genk, down in Belgium, about why we were here there. And it was ironically that the first case we operated with Ronald, it went very quickly, and I was like, okay, yeah, that's okay, maybe it was just lucky, it was a good patient. And then in the second case, as we were still speaking and scrubbing, his registrar started operating, and I asked him, so how long is this registrar with you? He said, no, it's his first month of the registrar. It's a junior guy, and the moment, like half an hour later, the registrar finished the case. So that was the first time I became interested when a registrar performed the direct anterior approach hip surgery. So since 2017, February, we in Tygerberg have done well over 500 anterior hip surgeries. Most of them were done actually for necrofemoral patients. And it was not just a road to happiness without bumps. So for the rest of this meeting, I want to introduce my panel. I've got 3 people on the panel with me. So if we're starting in order of seniority, it's definitely Lepalo Mukete. Lepalo, thank you very much for speaking with us today. So there's a common theme when you find with all of the panelists. So Lepalo finished actually his undergraduate in UCT before he went on to specialize in Johannesburg. He went around to Canada for his fellowship period and came back then to Charlotte Mukeke Hospital, and he's still in Johannesburg base. The second guy, Johnny De Beer, is the first guy I actually saw doing the anterior hip surgery. So Johnny again studied in Pretoria, then went to specialized in KZN. From there, he did his fellowship period in the UK, in Portsmouth, and came back to Mhlanga. And then, yes, it's always good to have good fresh blood, and that's why Hans is with us. Hans studied in Stellenbosch and then did his postgraduate studies in Pretoria. He also did his fellowship in Australia and came back to Steve Biko and is currently there doing anterior hip surgery. So I'm going to ask these 3 people to just share with you their story to happiness. And the road to anterior surgery wasn't always easy for all of us. And if I can start with Lepalo, I'm going to stop sharing my screen, and then Lepalo, I'll give you opportunity to speak first, and after that, then Johnny can speak, and then Hans, and then we'll take some questions if there's any questions from the audience. So Lepalo, over to you.
All right, thank you very much. Thank you very much, Chris, and thank you for inviting me to be a panelist. And I think it's already looking very, very good in terms of the success of this 4-part series. I suppose it's one of those that we can binge on once it's all recorded on video. So I come from Johannesburg, and I'm going to share my screen now. I've got a small presentation about my journey when it comes to anterior hip replacements. Okay. All right, so also a big thank you to Michelle for making this happen. All right, so like you, Chris, this is where I started. So I qualified as an orthopedic surgeon 16 years ago, and this is what I saw. So, and I was actually very happy with doing hip replacements using the Harding approach. And at the time of my training, I was also exposed to the posterior approach. And between the 2 approaches, this is the one that I settled on because this is the one that was mostly done at Charlotte Mukeke at the time. And also because, so as a registrar and as a young consultant, the one thing that absolutely petrified me is this, dislocations. And I absolutely didn't want to have a dislocation. And my experience was with the posterior approaches, there were a lot more dislocations than with the anterior approach. And with the lateral approach, sorry. And with the lateral approach, you know, it was reproducible, technically easy. You could do primaries, you could do revisions with it. And I was really, really happy with it, excepting for this problem, the persisting limp. Then I went to Canada and I was introduced to this translateral surgical approach. And it made sense on many, many levels, because suddenly the incision on the abductors, we were leaving a big ward of abductors at the back there, and also respecting the nervous supply of the abductors and the blood supply of the abductors. So as opposed to your hiding approach there, we were leaving a really, really big ward of abductors. And I thought that this was nirvana, because suddenly it made a lot of sense on many levels that you could do that. And certainly for the younger patient with good muscles, there was hardly a limp, but it was still a bit of a problem in those patients that don't have very good musculature. So it never quite took away the limp. And that brings us to this concept of perfection. And it's one of those concepts that are interesting in the sense that no matter how hard we try, we will never achieve perfection, but we try nonetheless. And one of the reasons is because we're always wanting to improve outcomes, and innovation comes into it as well. And we're always wanting to offer our patients the best accessible treatment. So around about the early 2000s, I attended a conference here locally. There was a fellow from the US, Dr. Beggar, and he came with this concept of minimally invasive 2-incision total hip replacement. So we were really seduced as orthopedic surgeons when we saw this. But the big issue with it was there were very, very high complication rates with this operation. So it really wasn't the operation for the occasional hip surgeon. And if you think that DAA, in terms of the learning curve, is very steep, this was even worse. But at the same time, I still felt that I could do better for my patients. Offer them faster recovery and certainly the reduced hip dislocation and less post-operative pain. So I was then introduced to this truly minimally invasive DAA, and essentially the AMIS approach. And at the time, I was a little bit skeptical, but then I started seeing the evidence, and the evidence showed that patients were a lot more satisfied with the DAA. So there was something in this DAA. And perhaps my feeling was that, okay, I am translateral, I'm pretty happy with it, but there is still those patients where I'm not completely happy. And my feeling was that I could still change and I could still do things in a slightly different way so that I could achieve, like you say, of course, happiness for me and for my patients. So I started looking at it seriously. And, you know, again, you get confused in the beginning because, you know, people talk about now that you can do it using a bikini approach. You can do the AMIS approach. You can do it with or without a traction table, with or without special retractors. And at the time, I traveled quite extensively. Went to the US, went to Europe to go and see exactly what it is that they were doing and how they were doing things. And also spent time with one of our local pioneers, Dr. Chuck, and also watched Dr. Joubert doing operations as well. And after a while, I was convinced that this was the real deal, and this is what I should be offering my patients. But what I can tell you is that I was definitely not one of the early adopters. I was probably in that bracket of early majority adopters, but definitely not a laggard. So I went for training, came back, and we started doing anterior approaches. Specifically, the aim is because I quite like the idea of using the traction table, because with the anterior approach or the DAA, my bugbear has always been that the acetabulum is okay, it's easy when it comes to total hip replacement, but the femur can be a little bit of a struggle. And it's really just lifting up that femur, getting it into the wound for you to be able to work. And I found that the traction table solved that for me. And not only that, but it also meant that you could actually do the operation with less number of assistants. The learning curve is 10 to 20 cases. So we also looked at our experience at Chalo Makeke. And so what is interesting about this slide is that you'll see that there's consultants and there's fellows. And what jumps out at you is that actually there's very little difference in terms of fellows and consultants in terms of the first few cases. And this includes all the complications, so minor and major complications. But most of the time, there were minor complications that did not require reoperations, including minor fractures. But by the time you get to case 21 to 30, you're having a lot less complications. And this, again, includes even wound issues, even minor wound issues. But by the time you get to 30 to 40, then you're really, really having very, very few problems. So like one or maybe two minor complications. So it's one of those that in the beginning, for sure there will be issues, for sure there will be complications, for sure there will be things that make you very, very uncomfortable, because as much as you're used to a certain way of doing things and you're comfortable with your approach, when you do change, there will be issues. And the point is you need to keep at it, because within 10 cases, you will be so much better in terms of your complications. So DAA is definitely the fastest growing approach to total hip replacements worldwide. It facilitates rapid recovery. And I think now we talk about 30% of primary hips being done using this approach in the US. I'm not sure of local figures, but local figures also, I'm pretty sure will show that it is the most popular now. Well, the most, in terms of growth, it is the one that is enjoying the biggest growth in terms of approaches to total hip replacements. So there are disadvantages for sure. Not all patients are suitable. There's issues with wound healing in obese patients and inflammatory patients with inflammatory arthritis. And that's certainly what our experience has shown. And also for me personally, I find the intra-op limb assessment to be a big issue. Although there are ways one can mitigate all these issues. And then again, Kurs asked me specifically to address the panel on why you need to be able to do DAA. Well, it is useful if you're doing a primary total hip replacement in somebody who's had multiple operations, where there's extensive scarring and you want to go through virgin tissue. And a lot of the time you'll find that that virgin tissue is actually in the front of the hip. Again, it is useful if the patient has pre-existing skin pathology. So this picture here that you see here was shared, a friend of mine shared it with me. It's a patient who had a fall directly on the hip and had a fractured neck or femur. So active patient in his 60s and comes in with a fractured neck or femur. So he actually had a Morel-Laval lesion in this area here. And this is the result after an operation done using the anterolateral approach. And perhaps if the surgeon had done a DAA, we wouldn't have these issues. Patients sometimes have psoriasis, and sometimes you see it is exactly where you want to do your cut. And this can be an issue. It's also one of those approaches that you should seriously consider in those patients that have bilateral pathology, where you're looking to do a single stage total hip replacement. So there's enough evidence to show that patients done through a DAA in terms of recovery, so short-term recovery, they do much, much better than patients that are done through any other approach. And this makes sense in those patients where you're considering doing both cases at the same time. Again, in those patients where you need minor revisions, so a patient is at a DAA and then you need to change the liner, what approach are you going to use? You have to go through that DAA approach. Easy to get into, easy to get out of once you finish the operation. And again, another instance would be where you have a patient where you're considering doing maybe a DAA procedure where there's infection or early infection. So you have to be familiar at least with a DAA so that you're able to attend to these patients. So of course, at the end of all of that, the whole world can be wrong. Why is everybody moving in that direction? So I'm convinced, and I am a DAA guy now. Thank you very much, Chris.
Thank you, Chris. Thanks for your talk, Apollo. Thanks, Michelle, and the rest of the faculty. It's good to share this. I think it's a great idea because it's so topical. And all of you know that as soon as you start changing your practice, there's a learning curve, which means complications. And in private practice, it can be a disaster to you. You just need one lady at the tea party to spoil your whole referral base. So my experience as far as the DAA goes back probably about 8 years now, where I also saw some leading surgeons on this panel operating, and I was very impressed with the anterior approach. I started off as well in Durban. I was anterolateral. Overseas, it was a posterior approach, and I fell in love with the posterior approach because in my hands, my posterior approach patients were off their crutches a lot sooner than when I did an anterolateral approach. And by no means do I say it's superior. I think that whatever you hear on this talk, it boils down to surgeon factors more than patient factors, more than approach factors. And you'll see some people, and I've seen some guys doing posterior approach and it looks like a dog's breakfast. I've seen anterior approaches that are horrendous. And it comes down to the surgeon's neatness and his ability to look after the soft tissue. And especially if you consider yourself a very neat surgeon, look at the anterior approach. But if you're not a respecter of the soft tissue, stay with the approach that you're using, because the anterior approach is not without its complications. So I started with traction supine, and I see in the poll that they didn't use the approach that I use. Chris, I should have spoken to you about that. I did supine on traction table. Then I started the lateral decubitus position. Then I went to the figure of 4 and then ended up back in the lateral position. The reason for that, like Apollo, I had challenges with leg length. And when I went to France and some of the other places, you'd put that big bone hook on your femur when you're trialing and you check the tension and you judge your leg length that way. And you can imagine with the traction, the external rotation, capsular release, it's very helpful to get exposure, but you're stretching everything else. It's very hard to tell your leg length. For me, I've seen guys do it very well, but I just couldn't perfect my leg length. And that's the leading cause for litigation in first world countries. So I never had a big problem with dislocation with my posterior approach, but now I was having a bit of problems with getting my cup changing. So you're changing your approach and then you change your position of the patient. Because in the lateral, when you're doing a posterior approach, you're doing it in a lateral position. So you've got two big variables now, approach and your position of your patient. And sometimes instrumentation too, because you get seduced into using short stems, which has its own complication list. So I had problems with over-anteversion of the cup initially, the anterior approach, and a lot of guys do have that. And you have to, as a posterior approach surgeon going to an anterior approach, you've got to be very careful with your cup position that you don't over-antevert it. Because otherwise you can have an anterior subluxation or instability, which might only present 5 years down the line with excessive wear. you have excessive anteversion on your cup. So I decided to stick to a posterior approach. It was easier for my staff to clean and drape. I don't have to worry about protecting the perineum, and the staff are used to one position. My speeds picked up and I was able to do posterior anterior approach more or less at the same speed, same blood loss. I presented my findings between the posterior and anterior approach at the arthroplasty meeting, and there wasn't a huge difference in my outcomes when it came to blood loss, when it came to date of discharge, when you use current local infiltrations and rapid recovery program. And at 6 weeks, the outcome scores were the same. But my patient selection was the thing. For the ladies and the smaller patients, you know, those who don't rehab as quickly as the muscular guys, I was doing anterior approach, but I was using posterior on the difficult cases that I considered would be hard to do an anterior approach on. And then the rehab was good. So it does look like the rehab is better with an anterior approach, but it's not very significant if you're dealing with young muscular males, because they recover just as quick. And also you simplify your life, you're going to reduce your complication rate, especially in the learning curve. So all the patients who had very varus hips, very narrow, short, thick, or narrow canals and thick cortices, where I knew I was going to have problems with these muscular guys, BMI patients, I was doing posterior approaches with good results. Another problem that I had with the traction table, maybe some of you can discuss this later and overcome that problem. I never overcame it. Was I couldn't take the foot out of the traction table during my trial, because I like to go into full flexion to see if there's any subspinous impingement, if there's any posterior impingement. So you can do that with the traction table, but you need to be able to do anterior and posterior stability checks during your trial. So you need to do a full range of motion, because more and more now the hip preservation, we're discovering extra articular impingements. And you see that not just with non-arthroplasty patients, but you're actually seeing that with arthroplasty patients too. Issue of femoral impingement with full extension, external rotation, deep flexion in neutral position, you get the subspinous impingement. So you've got to have a look at that, and you have to deal with that. It's very quick to remove those pieces of bone and prevent long-term problems. So I'm very happy at the moment with a lateral position. Very happy with doing both anterior and posterior patients. I had a patient this morning who had a colostomy for cancer, and it just, okay, patient's in the right position. I'm just going to go and stand at the back of the patient and do a posterior approach. So very complex cases, revisions. I believe in resurfacings. I do that all through posterior approaches. The easy patients, I'm a big believer in neck or femur fractures for anterior approach. I think that's a great thing. We know there's a high dislocation rate with those patients. A lot of them are elderly. They don't remember hip precautions. You don't want to over lengthen them because they have small acetabulums. If you haven't used a bipolar and you're using a hip, anterior approach, perfect for those patients. I do all of those through anterior approach. I did, when I was in Paris once, many, many years ago, I saw someone do a resurfacing through an anterior approach. And I think we also have to be very careful. And as men, firstly, as orthopedic surgeons, secondly, we often expect our skills to be more than what reality would dictate it to be. And we want to be able to do these things. And to do a resurfacing through an anterior approach, I think, is a contraindication. I've seen it done once, and it was very difficult. The guy put a cup in, tapped it this side, tapped it this side, tapped it, finally settled to a cup that was very anteverted and very, very open. So that was going to fail. So I think we've got to be very careful, and you have to be very honest with yourself. Can I do this safely for the patient with an anterior approach? Is it going to make a difference? And then do it. I also had a lot of help. I had a permanent assistant who was another specialist who was very good with anatomy. We did the learning curve together, private practice, to try and keep our complications to a minimum. The one advantage of doing it in a supine position is x-rays. It's more difficult to x-ray through your learning curve when the patient's in the lateral decubitus, but I would suggest that you use x-rays in the beginning. You're going to reduce your learning curve, especially with the stem positions. You've got to get lateral. and posterior at your entry point. And if you don't do adequate capsular releases, you don't deliver your femur, and you use a bailout as a short stem, you get it in varus, they fail. That's one of the biggest problems is femoral access, as Lopalo said. I agree with that. And you've got to make that exposure adequate so that you can get a good size femur. We'll probably see in the next discussions about the outcomes. The revision rates for posterior approach was more if you use 32 heads, okay, because of the risk of dislocation. So 36 heads was better in a posterior approach. If you use 36 heads in anterior approaches, the revision rate was more because of femoral stem loosening, which tells us one thing, is that our femoral stems are not always adequate with the anterior approach, because we're undersizing them because of the exposure. I think that's a good lesson to learn from the literature, and we'll see some of the case studies that you guys are doing at Tygerberg, and I was very impressed with the stem positioning there, and I think that's why X-ray is very important, is that we get that right, because otherwise we're going to have failures. You might not have dislocations, but you're going to have varus or undersized stems with premature failure. So there's a lot of advantages and disadvantages. Fractures, I think, are slightly more prevalent on a traction table as versus non-traction table, and we can see that even in Joel Matter's studies. As far as the private practice pressure is concerned, yes, we are seeing patients. I thought it would escalate more, but it hasn't really escalated over the last 5 years in the Mshlanga district. Probably once a week you'll get someone coming in and saying, oh, I hear you do keyhole surgery hip replacements. And I said, well, not quite arthroscopic hip replacements, but I always tell them, a hint to the surgeons maybe is, if you're using both approaches, is you can tell the patient, look, let's examine you and see which approach is going to be best for you. Because sometimes it's a shorter distance to the hip from the front, sometimes it's a shorter distance to the hip from the back. It depends on the habitus of the patient. And some of these patients you can't even feel the anterior superior iliac spine. It's just their muscle and their TFL, everything is just so indurated, and you know, if you open that skin, you're going to struggle to get that skin. That proximal part of the wound is the one that breaks down sometimes. But you can feel the greater trochanter very well. Other times it's the other way around. They've got huge bulbous buttocks, and you can feel the anterior superior iliac spine very nicely. And that's ideal. Even with BMI patients, you can do that through an anterior approach. So I choose my patients and my approaches very carefully. I don't want to make my life difficult. I don't want to have complications. And I explain to the patients, look, I'm happy to do it for you. However, I would strongly recommend that you can have a lower complication rate if we do this through a posterior approach, or I'll give them the option. I always test the patients for abductor strength, okay? With hip preservation, we're seeing more and more underdiagnosed trochanteric bursitis, which is actually abductor tendonitis, and after a number of cortisones or chronicity, they actually have undersurface tears. And if a patient can't stand on one leg for 30 seconds and they have pain on the lateral trochanter, you've got to be very careful. It might be referred pain from the joint, but it also could be abductor deficiency. And then an anterior approach is not going to resolve the abductor deficiency. And I see at least 5 to 10% of my patients. So if I did all comers through anterior approach, I will still have that problem later without addressing it surgically at the time. So then I do a posterior approach and do a mini open repair of the abductors. I still won't do anterolateral approach to repair the abductors. As far as colleagues are concerned, the physiotherapists, well, I can't wait to hear that talk by the physiotherapists, but a lot of physiotherapists were commenting on the anterior approach. So there is, when they speak, you've got to listen, because there's often a validity there. So if your neck of femurs are doing far better with the anterior approach than the physio tells you, you need to persist with it, because there is value in that. And the same when colleagues ask you to come, and the shoulder surgeon comes and says, please come and do this neck of femur, I want an anterior approach done, then they are seeing the value in it. And I think there is definitely value in the older female patients, and without a doubt, neck of femurs. The one problem that I did have with some of my anterior approaches as well, which some people would say minor complication, was the lateral cutaneous nerve of the thigh. I changed my incision to be more away from that nerve, and I had less problems with that. But that can be quite debilitating. There's not a lot you can do for that. And if you look at the literature, the incidence is very high in the literature compared to what I think we see in South Africa. The other thing is that if you test your patients at 6 weeks and you have them supine, you ask them to do a straight leg raise, and you press down on the anterior part of their ankle, so that you have a resisted straight leg raise test. With my anterior approaches, sometimes I will get a bit of inflammation, and I think it's between the capsule and the rectus femoris, and they have a little bit of a tweak. It does go away, but they have a bit of a tweak, and the patients who have a posterior approach don't have that. And then some of us might argue, yes, but you have more trochanteric pain after posterior approach. But I think you just got to be careful with your soft tissue management in the anterior approach, because that TFL, if that gets injured in a difficult case, and sometimes that happens, in a hurry and you want to get done and you're good at an anterior approach and you don't, your assistant moves the retractor. If you lacerate that TFL, they can have a dimple there and they have a chronic deformity there for life. You can't go and fix that. And there's pain there with exertion all the time. So you have to be very careful and patient during your learning curve with your TFL and gluteus minimus for that matter. And also just the management of your capsule. I believe in closing the capsule. I don't excise the capsule anymore. And I'll try and incorporate that with the rectus femoris. But I think I don't know if any of you else have seen it, but I have seen problems with anterior hip pain for the first few weeks afterwards, which I didn't see with my posterior approach. And I think it's got to do with the capsule and inflammation.
Thanks, Chris. Evening, everyone. It's nice to be the youngster sometimes. Just a recap from my point of view, I was solely a lateral approach surgeon up to the day I finished in 2016. And then I was off to Australia. And in Australia, if you're a lateral approach surgeon, they put you in the corner and they don't speak to you. So they only do posterior approach, and some guys do anterior approach, and the anterior approach is it's growing significantly in Australia. So the reason why I explored the anterior approach, I worked with two surgeons in Australia. One was the exclusive posterior approach surgeon, one of the finest surgeons I've ever seen, and brilliant outcomes in his patients. But every now and again, we had to take a patient back with a dislocation or revise a patient with dislocation. And with the other surgeon, we did mostly DAA or anterior approach figure of 4. And then we never had any dislocations in the whole year that I was there. We didn't have one dislocation. In his literature, he had one dislocation in 10 years, and that changed my thinking a bit. And I started off doing figure of 4 in Australia with him, but when I came back, I carried on with the figure of 4 for a while, but I found I struggled a bit, and there was no one in Pretoria that could help me. So I ventured into using the table, and that changed. It made it a bit easier for me. There was a lot more surgeons around here that could help out, and I found it a bit technically less difficult to do. So I was exposed to the lateral position anterior approach before I went overseas. And then I did figure of 4 while I was there, and when I came back, and I settled now with a traction table, and I'm quite happy with where I am. Although you get days where you actually wish you did the lateral approach still, but so it's not always just the perfect approach. You do have problems, and you have to accept that. The learning curve is as I see it, it's you're going through the honeymoon phase, the first 10 heaps. Everything goes well. There's usually a surgeon nearby to help you. And then it's the struggling phase between 10 and 30 heaps. We really start to struggle with your approach. And then you get to that cruising phase between 30 and 50 heaps. And then between 50 and 70, I found it where you actually go back into a dip, and maybe you make it too complicated, or you want it to be too perfect. And once you get past that, things become easier. So it is a learning curve, but I don't think it's more of a learning curve than any other approach. It's actually that we only do it later in our careers, where if we started off doing anterior approach as first-year registrars, it wouldn't have been a learning curve as we see it when you start off doing it in private and the pressures of doing it later on in your career. So the learning curve is basically for me more when you start doing it rather than it's a more difficult operation than any other approach. So yeah, so and one of my good friends or someone close to me got a hip replacement here in Pretoria from one of the most famous surgeons here, and she was very happy, but she had a severe limp, and at that stage I realized that we have to change things, and since then I can't say I'm an exclusive anterior approach surgeon. I vary it with lateral approaches still. We do some proximal femur replacements. We all do still lateral, but most of our neck of femurs now in Steve Biko Hospital, we do exclusively anterior approach. And when it comes to neck of femur fractures, we cement all our neck of femur fractures because I find that there's sometimes small cracks that you don't clearly see. And if you want to get a tight fit with an uncemented, you can exacerbate those cracks. And the patients have less femur or thigh pain, I find, if you cement the neck of femur fracture. It's an old habit that I haven't changed from lateral approach. I cemented all my neck of femur fractures, and I still do. And I actually went through a phase where I stopped using cement in the neck of femur fracture with the anterior approach, and I burned my fingers a bit. So I went back to cementing all my neck of femur fractures. So at Steve Biko Hospital, we train our registrars now in all approaches, but mostly anterior approach and lateral approach. So our neck of femur fractures that gets a total hip replacement, they will get a direct anterior approach, whereas if it's a bipolar or hemiarthroplasty, we still do a lateral approach. The reason why we still do a lateral approach on the hemiarthroplasties is for teaching purposes. The registrars get exposed to a lateral approach more often then. And the other thing is I found it quite difficult to reduce the big head of a bipolar with the anterior approach. And with the low dislocation rates of direct anterior approach, I'd rather go total hip replacement with anterior approach. And if I do bipolar hemiarthroplasty, I still do a lateral approach. So and we've got a stepwise approach in Steve Biko Hospital. So the patients come in, we do standard 100% X-rays, we do templating. I don't know if you guys do screen intraoperatively, but we don't routinely screen. But if we do more difficult elective type of hips, we do sometimes screen, but routinely we don't screen. We do an uncemented cup, not a dual mobility, normal uncemented cup. If we can go to a 36 head, we'll do a 36 head. Otherwise, a 32 head is sufficient, and we'll do a cemented stem. And that's our approach at Steve Biko Hospital. I agree with you, Johnny. When you do the trial, you are a bit limited in terms of the traction table. But I think once you start to get your cup more in a neutral position, because you tend to antivert it too much in the beginning, when you get your cup more into a neutral position, you don't get the posterior impingement that badly. But that said, I actually want to try and venture into maybe screening routinely if you get the software of some companies that can determine the cup position. Because at the moment, screening doesn't give me that much of an advantage if you can't clearly see what the position of the cup is in terms of antiversion and inclination. So yeah, it's been a nice road to anterior approach for us, although we still do a lot of lateral approaches. My patients are a lot happier. I think I've done 40 or odd anterior approaches in public before I started doing it in private, and I think that's the benefit of the teaching in public for the youngsters now, that you can go through that steep learning curve phase while you're still in public before you start doing it in private. So that was a big advantage for me, although we did see some complications, and and we did learn the hard way on some days, but generally the patients are much happier. We've had in more than 100 hips one dislocation, and we had every now and again we had a dislocation. So I think technically if you get past that 20-30 hip phase, everyone's happier. So our rehab protocol doesn't really change. There's a few restrictions that we don't have with the anterior approach that we still do have with the lateral approach, but mostly our rehab is the same from the physio's side. But we do see that the patients get discharged a bit quicker than our lateral approach hips.
Thank you. Yeah, thank you guys. So I've been happy to see that there's a amount of questions in the chat session. So the rest of the panelists are welcome also to comment there. For time's sake, I'm going to address these questions all now when we do the case discussion. So just as the rule for the panel, I'm going to put up the cases and you're allowed to answer only in one-liners, 2 at most. So no long sentences. So just answer the question and then we'll try to address each question that has come through the Q&A as well in the meantime. So I'm just going to share my screen again, and then we go straight into the case study series. Okay, so let me start. So all of the cases I'm going to show now is cases we've done either during the COVID period here in Tygerberg Hospital in the last couple of months. So the first patient is a young patient, quite a classic government patient actually. A female patient, known RVD positive, previous PTB, not very healthy, but also not, she's actually quite young still. So my first question is then to the 3 panelists, and each one can comment briefly on that, is do you exclusively offer DAA surgery for all your patients? Johnny touched on that a little bit, but for this patient now, would you exclusively offer DAA surgery for her?
So I would do the worst side first, and I'd do DAA.
Lepalo?
Yeah, so this is it's a classic patient where you could actually do both hips single stage in the same sitting. The only problem that we've always encountered with these patients is once there is RVD and it's been and you know this pattern of osteonecrosis, what then tends to happen is they tend to bleed quite a bit, and what you find is preoperatively the hemoglobins also are a little bit on the low side. So it's for that reason sometimes I'm not really candidates for doing a bilateral single stage, but based on the age, based on the pathology and what I see, she would absolutely be a good candidate. Then I'll leave it to the anesthetist intraoperatively to then say whether we can proceed to the next side or not.
So Hans, if I can ask you, do you do different consent then if you do a DAA surgery versus your conventional hip surgery? Is your consent at all different?
No, I don't change my consent at all. I just explain the surgery, what I'm going to do, exactly what approach I'm going to use. So I'll explain to them, I'll go through from the anterior side, the incision is going to be this big, the complications from going anterior is different to others, and I'll go through the whole thing, but I don't change my consent at all, no.
So do you tell them that you might get an ankle fracture if I do the surgery for you?
If I see an ankle fracture, I'll tell them about it. So I've only read about them. So.
Okay, so but what would you do for these patients if you address them? Single stage, bilateral stage?
No, I'll do a single. I'll do the bad one first, and I'll do a direct anterior approach. I won't necessarily. I usually don't give the patients the option to choose. I'll choose for them that I think that's going to be the best operation for them, and then I discuss with them. If they have questions about other approaches, we can discuss it. But usually I don't give them options of what approach I'm going to use. I'll just tell them I'm going to use, for you, I'm going to use this. So in this patient, I'll use a direct anterior approach.
Can I come back then to Lupalo? Lupalo, are you familiar with the term elephant ears in the female pelvis when you've got large iliac blades and then short necks? And do you think that that contributes to difficult surgery?
Yeah, of course it does. It does, but I mean, it also has to do with where you are in terms of the learning curve. So what we would advise with every single surgeon who gets onto DAA is that choose wisely. So don't do tough cases initially. Don't do patients that have short necks. Don't do obese patients. Don't, so choose wisely in the beginning, and you'll be rewarded for sure. But again, it has to do with where you are in terms of your learning curve. So for me personally, I'll be quite comfortable taking into cognizance the fact that yes, patient has got short necks. But I must say that initially I wasn't really a fan of using fluoroscopy intraoperatively, but with time, it's just one of those funny things where you find that as you do more and more and you think that you're able to finesse what you do, you suddenly find that there's actually a lot of value in using fluoroscopy intraoperatively. Maybe just to give you that extra feedback. But for me, I think also more importantly, it's you don't want comeback, so you don't want complications. And I think that it is the one thing that when you've done your 50 cases and you're now on case number 51, where things start to seem a little bit wobbly, like what Hans was describing, that's probably if you start using fluoroscopy routinely at that time, you'll be a happier DAA surgeon.
Yes, I can actually agree with you there. So we screen if we do a plating of ankle or something simple like that. But when we do a total hip replacement, somehow we feel we're not allowed to do a screening intraoperatively. So yes, I definitely advise that if it's possible to use screening more often. Can I move over to the second case and going back then to Johnny? Johnny, the bigger patients, this female with a BMI 41. Do you have any opinion about fat patients?
So of course, I'm very worried about the proximal wound healing in these patients. So if you look at this patient now, BMI, technically the neck is longer, there's more space, but it's those very narrow canals. I'd sometimes cement those because you get too small a stem down there. I use a longer, thinner cemented stem. But I generally would do posterior approach if I can feel the greater trochanter well. But if I can feel the anterior superior iliac spine well and the soft tissue is not doughy and under tension, then I'll do an anterior approach. So it's more about the soft tissue for me.
Hans, from your side, so I must say, we in Tygerberg in public have a lot of obese patients. You probably must see them as well.
Yeah, we did a direct anterior approach in a lady that was 160 or 170 kilograms a few months ago. And actually, the surgery went very well. And we thought, oh, we're great surgeons. Everything was great. And we had a lot of wound problems with her. I could agree with Johnny there that the proximal wound is terrible in a big obese patients. And actually, I've thought about this. You can do the surgery fine, but the anterior wound with a big mass of soft tissue lying, it just never dries up. So we actually took her back for a revision for a poly change. So beware. I think it's different types of fat people that changes your decision making. If they've got a lot of obesity around the tummy that lies on the wound, those are the wounds that's not going to do well. The ladies that has got a thinner tummy and a broader around the hips, those are the ones that you can actually treat with a DAA without wound problems. So it's a different type of of soft tissue problem, but yeah, I don't. Maybe I'm going to change my protocol according to the weight.
So to continue with these cases, the first case, like we said, is a classic case. We see them in every clinic, and we adopted the approach to do them at stage, so 6 weeks apart, and so far we had good results with this. So this is our standard approach. Then we used in Tygerberg the figure 4 DAA technique on a standard operating table. We don't use fluoroscopy routinely because there's not enough fluoroscopies available for all the theaters that runs during the day. But the approach is whenever there's any difficulties or whenever you struggle, anything goes wrong, we have a low threshold to get fluoroscopy for that case then. I don't know any of the panelists wants to comment. You're welcome on the post-operative X-rays.
I think that's a very nice looking X-ray. You restored the leg length, you correct the other one. The cup position is often the problem with these approaches, and your cup position is very good there. You've got a good 45-degree angle. The biggest problem with these approaches is a cup that's too open and too anteverted, but that one's nicely done.
Thank you, Johnny. I'm far enough, so I can't do anything to say anything horrible though.
Chris, do you guys use any navigation or something else to determine the cup position, or just freehand?
In Tygerberg, we're quite strict on the 3-finger rule. In the DA, we go for absolute anatomical restoration of the acetabulum. So we try not to antevert. We try to go 100% neutral to the TAL. That's the first rule. Second rule is go onto the true floor, but not past the true floor. And the third finger, whenever you go for any anterior base surgery, to always make sure there's bone to protect the psoas. So the anterior wall, you must feel very carefully that you don't get psoas impingement. So we're quite vigorous with that. We don't do navigation for hips. We do it for knees, though. We use the robotic systems for the knee, but not for hips, no. So going to the second case, this is an interesting case more because this patient became acutely wheelchair bound during the COVID period. So this was one of those times that we tried to push the envelope, and we offered her then bilateral simultaneous surgery, which is not something we often do in Tygerberg. So as it happens in the academic hospital, one I did and one the fellow did. So I won't disclose which side was mine, otherwise maybe the fellow was better. But I often found that when we do bilateral simultaneously, it's actually difficult to get them to look precisely equal. I don't know, do you guys struggle with that at all, Lopalo?
Yeah, so it's an interesting question that you pose, because at the end of the day, they are two different hips, and you have to take cognizance of what you put in on the other side, but that should not force you to absolutely and completely replicate the other side, because at the end of the day, they are two different hips, and you need to treat them as two different hips at the time when you do the surgery.
So Hans, if you do that in the table technique, so obviously bilateral is how easy is that?
Obviously, the table limits you doing bilaterals. If you, that's the big advantage of the figure of 4, is one draping clean, and you can do bilateral total hip replacements. I don't know if our setting, if we use the figure of 4, if we would have done bilateral hip replacements. Our patients are not usually fit enough for that type of surgery, but definitely a big advantage for figure of 4 over the table is to do bilaterals. Yeah, but there's also guys doing bilaterals with the table. It's just a bit of a tea break in between.
So Johnny, from your side, on the lateral decubitus position?
So firstly, for me to do a bilateral, it's easy. I do it, turn the patient around, do the other side. Infection risk is low because I re-scrubbed, re-draped. I don't like doing bilaterals because I think the risk of infection is higher in the patients. There's some literature to suggest bilateral arthroplasties. It's a greater physiological insult. So especially if you've got ASA3 patients or ASA2, like retroviral pulmonary TB, I'd never do bilateral. I think it's too dangerous from an infection risk. And then from looking at this X-ray, as far as positioning is concerned, you can see that the radiology is the problem here. The pelvis is slightly tilted. The left leg is externally rotated. The right one is in neutral position, the foot. So that's why it looks different. You can see more lesser trochanter on the left side. But I think it is important that we get our cups at 45 or less. So we should be measuring all our cups personally and making sure that our cups are not 50 degrees. But it's a lot of those, what you're seeing there is positional, the way the radiographer held the legs.
Okay, thank you. If I go to the last two cases, so complex cases. So from Hans, if I go back to you, do you distinguish between acetabular pathology, acetabular complex cases, and femoral complex cases?
Yes, definitely. So usually for me, the more difficult acetabulums are the ones with less coverage. So the dysplastic hips poses a bigger problem for me than the protrusive hips. In the anterior approach, you get a good view of the medial wall. And if you've got good coverage, anterior and posterior, usually you get the cup seated pretty well. Whereas with the dysplastic hips, you don't see the edge of the superior wall that well, like in some other approaches. And if you want to do a superior wall reconstruction, it also limits you, whereas in some of the other approaches, you can get a 360 view. So a protrusive hip is not a big of a problem for me in a anterior approach. You get the cup seated pretty easily and do a bit of a bone graft medially. But I find dysplastic hips to be quite challenging.
Lapala, would you go posterior or anterior?
So posterior is not my thing. So my go-to approach is anterolateral. So it either be anterolateral or DAA. And look, in this specific case, it is pretty complex. A lot of it would also depend on how much movement there is in the hip preoperatively. But I think what is key in all these cases is templating. And the templating has to be absolutely exacting. And essentially what you template has to be pretty close to what you put in. And if that is not the case, then you've got to have the fluoroscopy in to see exactly where you are and what mistakes you're making. So in this instance, in this specific case, if you choose to go DAA, I would say you have to have the fluoroscopy in theater.
So Johnny, would you go then posterior for this case? Because in the past, that would have been it's a difficult posterior approach.
I would definitely go posterior approach here. I think the risk of me fracturing anything there is going to be a lot lower, the posterior approach for that left hip. I think the right hip, that profunda hip on the right, you could do through a DAA, you know, if you've passed your learning curve. But definitely for me, I have a low threshold to go posterior approach.
So I always struggled. I mean, this posterior was my dedicated approach for this, but this femur is very externally rotated. The moment you go past the colus line, to get your inside to neck cut is very difficult through the posterior approach. You normally have to do a cut and then a secondary cut and hope you don't cut into the lesser trochanter. So for us, I must say this was the big surprise when we ventured anteriorly for the protrusio case. Like Hans was saying, it is actually quite easy because you do your cut of the neck, and then you can take out the head, and it's really a very easy approach. And for the protrusio, so we actually find them to be one of the easier complex cases to do via the anterior approach.
Your problem is your femoral access, not your acetabular access there.
I agree. So, so you released your femur, and then we didn't have much problems with that. Yeah, I don't know. It's well. So going over to the last case, and then we show the extras for the ones in the middle. This is a controversial thing, neck of femur fractures. And I have very strong opinions about this, so I should try to keep quiet. Firstly, do you guys do anterior surgery for neck of femurs? Do you recommend it? Do you recommend that we train people to do this? And
Yeah,
we can start with Paulo.
Yeah, I see no issues with that, to be honest with you. And I think also this is where the traction table also comes into its own, because you can restore some element of normality of the anatomy by just putting the patient in traction, and that allows you, I think it makes it a much easier approach to get into the hip if there's a little bit of traction where you try and restore the normal anatomy. That certainly is my experience. And the only issue with it is the tissue plane sometimes can be disrupted, and there's also there can be a lot of bruising, and you don't see things as clearly. And when you get guys started on DAA, sometimes I feel that as much as fractures may be low-hanging fruit, that it's probably not the right cases to start them on, because the anatomy is not quite normal. There's disruption. The tissue planes are not quite normal. And then with the edema as well, and just bruising, the colors are not what you would normally expect. Makes things a little bit difficult when you consider doing DA in those cases. So I would say if you start with total hips and not fractures. If you can, that is, as you go through your learning curve of the first 10 cases.
So Hans, how do you guys feel there in Pretoria?
So initially we started off doing it only in total hip replacements and not in the neck of femurs, and then I quickly realized we are bombarded with trauma, and a lot of times we have to cancel our elective cases because of the trauma load. So then we started doing exclusively anterior approach to all our neck of femurs, and since then the learning curve and the registrar being involved in the anterior approach has improved significantly, because mostly the registrars are involved in trauma surgery. So suddenly they were doing 5 or 10 anterior hips in one rotation. So I do find a neck of femur slightly more difficult than the elective total hip replacements anterior approach. And the reason is that the acetabulum's got soft bone and you don't have a lot of bone to work with. So your reaming has to be sequentially perfect. And I've changed it over time a bit. So at the moment, I ream very little immediately, barely anything, up to the size where I start to catch some walls anteriorly and posteriorly. And once I get to the size that I find is the appropriate size, then only I deepen ever so slightly. And then we get our cups to sit. It's strange to think that you struggle to get your cup seated in a neck of femur fracture when you've got this perfect acetabulum. But for some reason, you struggle with the acetabulum sometimes in a neck of femur fracture because you don't see the acetabulum 360 and you don't have that sclerotic hard bone and a lot of bone like you see in the elective hips. That being said, the femur is much easier. So a lot of times doing the femur, we don't do any releases on a neck of femur fracture. So a 70-year-old lady, flaccid soft tissue mostly, we get the femur out without doing any releases. And that's a big advantage. starting off with the neck or femur fractures. But beware with the neck or femur fractures in the beginning. It can catch you.
So, Johnny, there was a question on the Q&A session that can you do hemiarthroplasty and cementing in via the DAA, and do you do anything different if you need to do that?
So, Chris, I think on the very top of my list for DAA is neck of femurs. You know, Hans and Apollo are right. It's more difficult, but you know, when you're doing a neck of femur through an anterior approach, your dislocation rate is low, and they're used to a full range of motion, so they're going to push this hip to a limit. I do cement. You guys are getting very good results in Tigerberg with uncemmented, but I cement all my stems. I'll do hip replacements if they're active. Otherwise, I'll do a bipolar through anterior approach. The only thing is I release the capsule a little bit more on the superior part of the acetabulum, and then I close it again, because that allows you to reduce the big head, as long as you don't lengthen the leg. So I have a very low threshold to do a cemented bipolar through an anterior approach. I think that's the most important indication for me in my practice for DAA.
So yes, I agree. And the first question, I see there pops a question up, and I think the question will probably be about the capsule. Let me just see what it is. Does the approach change the preference in articulation options? Lip liners seem to be popular in poster approach. What about DAA? So yeah, I can give that question to you, Lepalu. I haven't used the lip liner, in a very long time, even in the poster approach. So I don't know if you're a fan of the lip liner.
No, so again, we don't use lip liners. So even with anterolateral approaches, we don't use lip liners. And more so with anterior approach. So the only instance where maybe one would suggest a lip liner is if you've severely antiverted that cup, and you've already put in screws and you put in maybe a trial liner at that point, and you can't really change that position, then you might just use a lip liner just to help yourself with that extra anterior coverage, so that the hip doesn't dislocate. But other than that, yeah, lip liners is not a thing that I use.
Johnny, from your side, do you use lip liners a lot?
Not in anterior approach. I've had it, like Apollo says, where I've had antiverted cup, but the problem is, put a lip liner in, you're going to impinge anteriorly a bit. So I never put the lip liner in the front. I always put it at the back, and that's only in the posterior approach. With the anterior approach, I do it, you were saying earlier, I don't know if it was Apollo or Chris, you aim for that cup position with a TAL perfectly, and then you don't need a lip liner with the anterior approach. I'll sometimes use it more frequently with the posterior approach, but I never use it in an anterior approach.
So Hans, if I can ask you one last question before I move on, is Peter asked, how do you judge retroversion of the acetabulum through the DAA? How do you deal with that retroversion cases in a DAA scenario?
So basically, I use the anterior wall as reference, and I go as neutral as possible according to the anterior wall. I just want the cup just buried under the anterior wall. So the anterior wall is my reference. So if the native acetabulum is more retroverted, your cup would possibly be slightly more retroverted. But my reference will be the anterior wall, and I just bury it under that you don't get any psoas tendinitis.
Yeah, so from my side, I can say that the retroverted acetabulum is a very tricky case through the anterior approach, because they do dislocate anteriorly more easily, because you often get your anteversion wrong with them. So the moment I've got the retroverted acetabulum, you must first look at the spine at the back. So is this a retroverted pelvis or a retroverted acetabulum on its own? I've become quite bad if it's a retroverted pelvis. In that stuck standing position, then I will go for dual mobility straight away. And I still do that through the anterior approach. That's the only time I upgrade my constrainment through the anterior approach, is if I have this retroverted pelvis. For the retroverted acetabulum per se, I would normally just go for a standard neutral as a tabulum through the anterior approach. We go for neutral, neutral, and that normally is sufficient for stability. Jurek, I see that you wanted to say something, to answer Tane for something. Can you tell me? Jurek, are you there?
Yes, I was simply agreeing with Thane about using the soft tissues and seeing if they all matched up. And I think the important thing, once again, as was alluded to, is that with direct anterior approach, you certainly can be far more meticulous with your soft tissues, and of course, then subsequently restoring the anatomy and the biomechanics. So yes, I agree with Thane that using that trick, and Dr. Chakic does it very elegantly in restoring it when he also sutures the capsule at the end of the surgical procedure, which I know some surgeons don't necessarily repair the capsule in a direct anterior approach, but I definitely think it can be used as a way of ensuring that you've restored your limb length.
Thank you very much. So we're running out of our time sequence. So I'm just going to show what we've done with these two cases. So like the speakers were mentioning that, yeah, I found the protusia patient quite easy, and we do impact and bone grafting for them. And it was actually much easier than my traditional posterior approach to do them via the anterior approach. For the neck of femurs, yeah, we've done everything. We cement indicated, for example, today we did a cemented bipolar on one of them. So we do cement if it's pathological, if the bone is bad, or if you don't get a good fixation of an uncemented stem. And we have a low threshold for that. But we use quite a lot of these collar prostheses in Tygerberg. And the active patients, we normally go for a standard 32 millimeter head for all our neck of femurs. The only time, like I said, we will go for increased constraint is if they've got spinal pathology that will cause a problem for that. But yes, the neck of femurs is a debate on its own, so I'm going to leave that one for a later time. So I'm going to ask for any last comments from the panelists and any other questions which will come through before I open the floor for that. The next episode will be next Monday. So next Monday, we're going to run a pure academic session. So it's going to be short talks on why you should or why you shouldn't do it. What's the evidence? What's the literature saying? And then we're going to end that up by a Q&A session and a couple of short cases that Hans is going to show us. So please tune in again next week, same time, same place. If you want to know more about the academic side, especially if you're against us, because we'll try to make a good argument against this as well. So any last comments from my panelists?
Chris, if I can ask you...
Just a thank you for the symposium. I think it's been a great success. But I just wanted to highlight that, one of the things that we found when we looked at the cases done at Shalomakek at Johannesburg Hospital was that if you look at the complication rate for the fellows and the consultants, it is the same. So I must say that I've always had a fear, should we be starting trainees on the DAA? But you then start to realize that if all that the trainees know is a DAA, they will do just as well with the DAA as any other approach, because that is their approach. So it has certainly changed my approach in terms of, as much as we know that there's a steep learning curve, but I feel that we should be getting more of our junior trainees started on the DAA much earlier than when they get to be fellows.
So before we go to any closing remarks from Hans?
Yeah, Chris, I just want to ask you last clinical question. Do you guys ever consider doing 36 heads in your anterior approach or in your neck of femur fracture anterior approach? And do you see increased periprosthetic fractures in your neck of femur fractures if you do an anterior approach with undersizing maybe compared to, say, posterior or lateral approach?
So quickly, we don't do 36 heads unless we go above a cup size of 60. So if we go under a cup size of 60, we stick to a 32 neutral head in the DAA from all the neck of femurs. Periprosthetic fractures, we haven't had a single femur fracture. We had greater trochanter fractures, and that's from very enthusiastic registrars that put the Homan very through the soft bone at the tip of the greater trochanter. That would be one of our commonest actually complication if we have a bony complication with the neck of femur fractures. I hope that answers you. So Johnny, from your side, any last comments, and then we're over to Michelle to wrap it up for us.
Just maybe one comment on the capsule. I think we must try to strive to preserve the capsule. Don't kill the capsule like we kill the biceps. It will reduce your seromas, and it might have a proprioceptive and stability function too. Thanks, Michelle.
So, Dr. Jordan, Dr. Jacobs, De Beer, Dr. Moketi, thank you very much to all of you. Really, I think a fantastic start to this 4-part episode, and hopefully future face-to-face meetings. I promise I'll buy the first round when we get together face-to-face. Just to also thank the team in the background, as Ruby and Leonie, I think you've done a great job. And thanks to everybody who's joined this meeting, all the rest of the panelists who we'll hear from in future episodes, and to all of the attendees. Thank you very much.
Thank you very much, everybody. Good night, good bless, and goodbye.